In trials, treatments, in data collection, men were just as good, and you don't need to know anything more about the impact on women's health. We know that now to be false.
It's the leading cause of death for women in the US and UK. Yet there is a misperception that heart disease mainly affects men. But in the US, almost as many women as men die each year. And this lack of knowledge and inequity of care is costing lives. Now, experts in America are calling for greater awareness and action via a presidential advisory issued by the American Heart Association. Cardiologist and corresponding author of the advisory, Dr. Veronique Roger, says women are continuing to be underrepresented in research for cardiovascular disease, which is a general term for conditions affecting the heart and blood vessels.
I think what's particularly concerning right now are two things. One, the fact that the trends in cardiovascular disease death, which had been declining since the mid-1960s, have been gradually stagnating in terms of the number of deaths as well as the rates in different populations. And this has been the case for men as for women. And even in more recent years, we've seen an indication of a possible increase in the rate of death from cardiovascular disease among women. The second factor that gives a sense of urgency to this topic is really the intersection with race and the issue of a particularly high burden of cardiovascular disease morbidity and mortality among women of different racial and ethnic origin, in particular Black persons, Black women in the United States.
According to the World Health Organization, globally, heart disease is the leading cause of death among women in high-income countries and the second in low- and middle-income countries. In America, cardiovascular disease accounts for about 1 in every 5 female deaths. To improve these outcomes, Dr. Roger says there needs to be a cultural shift.
The medical profession has a responsibility in engaging women in the prevention and management of heart disease throughout their life course. And I think this document, in a sense, also calls for a multidisciplinary partnership between not only cardiologists, but also primary care, gynecologists, obstetricians, to really manage the cardiovascular risk in women throughout their life course.
So what are the inequalities? Do women face them throughout treatment from diagnosis to recovery?
The journey of women through cardiovascular care has been the topic of interest since probably the early 1990s. I mean, it's at that time that the term gender bias was coined, which was a way to frame the differences in the care delivered to women and the differences in outcome. And this was grounded in the perception at the time that heart disease was a disease that would affect middle-aged men and did not affect women. I think that perception has changed, but we're still facing some differences in perception of the level of risk between men and women, and also a sense that the presentation of cardiovascular disease is, quote, atypical, unquote, in women. There is no reason to label the symptoms that half of the population of the globe experience as atypical. I mean, they are what they are. We need to recognize them and manage them, as I said. So that's part of that cultural shift.
But there are some risk factors which are unique in women.
In particular, in the last few years, and it's a good thing, there's been a lot of emphasis and interest in understanding better what happens around pregnancy with women presenting to pregnancy sometimes with already existing hypertension, overweight, and the particularly hypertension that is present before pregnancy is exacerbated during pregnancy oftentimes, and it can lead to hypertensive diseases during pregnancy, preeclampsia, eclampsia, and that these are really lay the ground, if you will, for the occurrence of cardiovascular disease in women after the pregnancy. And so the importance of investigating these risk factors and managing them proactively in the time surrounding pregnancy, before, during, and after is really, really important. And fortunately, there's intense interest right now in the cardiovascular community in the United States to address those issues.
Historically, there has been a lack of data around how cardiovascular disease affects women, and the consequences of that have been fatal, with many underdiagnosed and undertreated. And remember, this isn't just in America. Research funded by the British Heart Foundation suggested more than 8,000 women died between 2002 and 2013 in England and Wales because they didn't receive the same standard of care as men. In America, do these inequality gaps exist because men have been studied more than women?
We were lacking data on women in terms of the effectiveness of the major vectors of management, if you will, of cardiovascular disease among women, simply because women were not included in clinical trials. And the reasons for that are likely multifactorial. Certainly there were concerns about pregnancy and impact on an unborn child with some medication, some management, the issue of radiation for some testing that were done. But I think this line of thinking has become largely obsolete, and I think it's really important that, and there is a major effort to include women in clinical trials nowadays. Now, there's also an issue of perceived desire from the participant to be included in clinical trials, and we need to continuously remind women that to have data that are valid in women, we obviously must study them in clinical trials like we've studied men.
So we've been discussing the historical bias in cardiovascular disease, but this bias extends throughout medical science, according to Catherine Schubert, the CEO of the Society for Women's Health Research in the US.
For many decades, women were not viewed as any different than men. In trials, treatments, in data collection, men were just as good, and you don't need to know anything more about the impact on women's health that you could not get from men who were included in trials. And so we know that now to be very obviously false.
As well as the concern around pregnancy, women were also thought of as difficult test subjects because of fluctuating hormone levels, which even extended to animal models. And Catherine says that historical bias continues to persist. So what have been the consequences?
Well, we know that in some cases, drugs or medications metabolize different in women than in men. We have seen this very clearly throughout the last couple of decades in terms of drugs or medications either not being as effective as they could be or potentially being more effective and in fact unsafe potentially because it was not considered to look at those hormonal changes or metabolic changes. The physiology is very different. The other piece, which is huge, is that oftentimes women are prescribed medications that have not been tested in them. And so we just don't know whether they're safe or effective. We see this, I think, probably in the most clear example would be in pregnant women, women who might have a chronic condition that needs to be managed during pregnancy or something that happens during pregnancy that would require medication to manage it. But we do not have any guidance really for the most part in terms of what's safe and effective for them because it just hasn't been studied.
There have been improvements. In the US in 2016, the National Institutes of Health brought in a policy that sex as a biological variable must be factored into research designs and data analysis and reporting of vertebrate animal and human studies. But more can always be done.
We really have to be thinking about the long term, what happens before the reproductive years, during and after. Looking at this whole woman approach so that it's not just known as, quote unquote, women's issues, I think will go a long way. Not just one aspect, one organ, condition, disease, or life stage is going to be critical. We also know the costs of not including women in trials, and we know that those are astronomical to the economy, to society, to families, and frankly for generations to come. A recent Women's Health Access Matters report found that if you invest $300 million in women's health research, that will generate $13 billion to our economy. And so we're a huge consumer in the market. We're not seen as such. We're underfunded when it comes to investing in women's health research. So while awareness of certain conditions has grown, the federal investment has not. In fact, it has not been prioritized. And I think right now industry is just starting to look at this space as an opportunity for innovation, but we still have a long way to go.
With patients facing shrinking amounts of time available on visits to their doctor, Dr. Rogier agrees there needs to be more innovative care models in the community. Instead of going to a medical practitioner, why not get your blood pressure checked at the gym or pharmacy, even the hairdresser? Giving easy access to a simple healthcare check to assess risk and encourage greater awareness and self-care.
I think people are keenly aware of the importance of the topic, and so there's intense work that's happening, again, under the auspices of the American Heart Association, but also other groups as well are actively working on this. And I think in a number of, hopefully, maybe not months, but certainly hopefully a year or two, we'll have better tools to quantify that risk so that this holistic care can be deployed.